So I've been asked to give talk on whether intramuscular adipose tissue is good or bad for metabolic health. I don't have any conflicts of interest relevant to this particular topic. So first, I started my reading for this lecture by trying to find out what we mean by intramuscular adipose tissue. And as Dr. Yajnik has mentioned, we have different depots of fat in the human body, whether you like it or not, and unless you're Dr. Yutkin, most of us have 25 to 30% fat in our body. Trained athletes might have as little as 15 to 20%, but it's very unusual to get somebody who has less than 10% of fat in their body. But this fat is distributed into various depots in the human beings, and you have two types of fat, namely the white adipose tissue and the brown adipose tissue. Now, the brown adipose tissue seems to be a total outlier as far as all the pathogenic mechanisms of fat are concerned. It seems to be more related to thermogenesis with uncoupling of the oxidative phosphorylation, and I understand that we are having a talk on brown adipose tissue subsequent to mine. And this is found mainly in the supraclavicular area as well as the subscapular region. So I will not be dwelling on this at any great length during my lecture. Now, the white adipose tissue is found mainly in three sites. The first site, which is probably the most visible to all of us, to our despair mostly, is the subcutaneous fat. And the subcutaneous fat is mostly found under the skin of the anterior and side abdominal wall, which is mentioned here as A. This is in the abdominal wall. And we also have a depot of subcutaneous fat in the gluteofemoral region. Now, subcutaneous fat thus far has been considered as a good guy. And it has been considered that you can have as much of subcutaneous fat as you like because it is metabolically inert. It does not secrete any adipose cytokines and does not cause any metabolic derangements. But we now know that there is some difference depending on whether you have subcutaneous fat in the abdominal wall or whether you have it in the gluteofemoral region. And the gluteofemoral subcutaneous fat is considered to be protective against metabolic disease, whereas no such link has been shown with the abdominal subcutaneous fat. Then, of course, we have the bad guy, that is a visceral fat, which is fat depot found surrounding the abdominal organs, in the omentum, around the kidneys, around the heart, you name it, you have it. And there have been lots of studies looking at visceral fat in the general world population as a whole and in Asian Indians as a whole, showing that Asian Indians tend to have excess of visceral fat. And that is what we actually measure when we try and measure the abdominal circumference. That's a very crude surrogate marker for the visceral fat. So this is considered to be bad for metabolic health. It secretes all sorts of adipocytokines leading to inflammation, insulin resistance, and type 2 diabetes, and you have it. You name it, you have it. Now, the third depot in which what we are interested today is the ectopic fat. And muscle is one of the main sites where you have ectopic fat. And you can have different types of muscle and fat. And the two main types of muscle and fat are what is known as intramuscular fat and intramuscular fat. Now, what do you mean by intramuscular adipose tissue or IMAT? Intermuscular adipose tissue refers to those adipocytes which are present in the spaces in between the individual muscles, under the muscle fascia, but in between the individual muscles. And the intramuscular adipose tissue refers to those adipocytes which are found in between the fibers of the individual muscles in the muscle bed. You can also have other types of fat in the muscle like intramyocellular triglyceride, which is the triglyceride accumulating within the individual muscle cells. And you can also have what is known as perivascular fat, which is fat which is located near the blood vessel supplying the muscles. So we are more interested in the intramuscular adipose tissue, and this is what the intramuscular and intramuscular fat looks like in an animal. In fact, it's considered to be good for the animal, not for the animal, for someone who eats the animal if you have more of intramuscular fat. And that's what is known as marbling of fat. In fact, animals have been selected for the ability to retain fat in the muscle. So it adds the flavor and texture to the meat. So what you see here surrounding the individual muscle fibers is what is known as intermuscular fat, this white. And what is in between the muscle fibers here as a center point is what is known as the intramuscular fat. And this is what it looks like in the human beings in MRI scan. You can see this is the subcutaneous fat right here surrounding the abdominal wall. You can see here the Intermuscular fat between the muscle fibers and intramuscular fat within the muscle fiber, between the individual muscle fibers. So where does intermuscular adipose tissue originate? Like Dr. Yajnik said, all these things happen during intrauterine life, and subcutaneous fat depot is supposed to develop first. And this is followed by the visceral fat depot and then only by the intramuscular fat depot. But early development of muscle adipose tissue occurs during embryogenesis, and it becomes a distinct depot only in the third trimester. And there is noticeable growth of these ectopic fat depots during periods of rapid postnatal growth. But during adolescence, the growth of intermuscular adipose tissue slows while that of intramuscular adipose tissue increases. These are just observational findings. We really don't know what are the implications of these for metabolic health. So where does it originate from? What business does fat have in the muscle, and how does it come into the muscle? Now for that we need to know something about the stem cells which are there in the muscle, especially what is known as the muscle satellite cells. Now these are committed stem cells which are found in close proximity to the cell membrane of the myofibers. And these are actually pluripotent cells. Even though we say committed, they can give rise to cells of various lineages. So normally the role of muscle satellite cells is in muscle growth and repair. During periods of rapid growth, as occurs in adolescence, or when you train the muscle, these satellite cells can get converted into muscle progenitor cells, or MPCs. And these muscle progenitor cells put out more of muscle fibers, or they repair those muscle fibers which are damaged by trauma or overuse or whatever. But under certain circumstances, especially under the influence of genes such as PPR alpha, delta, and PPR gamma, and the WNT signaling pathway, these satellite cells can also give rise to adipocytes. And that is where the muscle fat originates. In addition to the satellite cells, you also have progenitor cells which are circulating from the bone marrow, and they are present in the blood at all periods of time. Again, during certain circumstances, they can give, it's easier for them to differentiate to adipocytes than for the satellite cells to differentiate to adipocytes. So under certain circumstances, they can differentiate into adipocytes and get deposited in the skeletal muscle. So these are the two main sources of muscle adipose tissue. So how do you measure intramuscular adipose tissue? There are two imaging modalities that have been widely used, CT and MRI. MRI is considered to a higher sensitivity because it delineates the details of soft tissue better. The problem with MRI is that it is time consuming, and it may not be very good in picking up very small islands of fat cells, for which CT is much better. But both methods have been considered to be acceptable. The only thing is that when you are doing a longitudinal study, you need to follow the same technique before and after whatever intervention you are trying to give. You can hear this is the quadriceps muscle cross-section of two women, and you can see both of them have more or less same amount of muscle. In fact, if anything, the woman on the left has more amount of muscle, but you can see the woman on the left also has higher amounts of adipose tissue which is interjected between the muscles. So this lady has more of fat in the muscle as compared to this particular lady. So this is a diagram which has been derived from an MRI scan image. So the next question, the important question is, does it matter if you have too much of intramuscular adipose tissue? So these are some of the conditions associated with increased IMAT. I don't say that these conditions are caused by increase in muscular adipose tissue, but these are certain associations. They are found in obesity, type 2 diabetes, metabolic syndrome, aging, post-stroke, post-spinal cord injury, acromegaly, certain lipodystrophies, especially familial partial lipodystrophy, and in individuals who are sedentary. So none of these conditions are actually very good for health. So that itself tells you that having too much of IMAT, it may not cause ill health, but it may be associated with certain conditions which are not good for you. The intramuscular adipose tissue mass in the body has been positively correlated with insulin resistance as well as risk of type 2 diabetes. This is a study which was done around 15 years ago in the US in women, both white and black, and you can see that as the intramuscular adipose tissue increases, the insulin sensitivity decreases, both in whites as well as in blacks. And you might say, of course, when the BMI increases, your IMAT also increases, and maybe that's the reason why the insulin resistance increases. But this association is maintained even after adjusting for the BMI. So it's to an extent independent of BMI. But we really don't know whether it is a marker of metabolic dysfunction or is there a direct pathogenic effect of having too much of fat in the muscle. Does it really have an effect on the insulin sensitivity? That question is still open. Some authors say that if you have more of fat in the muscle function suffers. You're not able to have sufficient amount of mobility, your muscle contraction strength decreases, and that in itself leads to increased inactivity. So a vicious circle is set up. You have more fat in the muscle, your muscle doesn't contract properly, you are more inactive, you put on more of fat in the muscle. So that sort of vicious circle sets in. And this most clearly seen in individuals with diabetes and post-neurological injuries like cerebrovascular accident and spinal cord injury. So that is one way of looking at it. The other way of looking at it is that we know that visceral fat elaborates a lot of cytokines, which are not good for you. And ectopic fat behaves more similar to visceral fat than to subcutaneous fat. It also secretes lots of these pro-inflammatory cytokines, and these can result in local inflammation in the muscle. And probably because of this, the whole body glucose metabolism is decreased when you have more of intramuscular adipose tissue. And the possible mechanisms which have been postulated include the cytokines, as I said, impaired blood flow. If you have more fat in the muscle, the blood flow to the muscle is impaired, increased rate of lipolysis within the muscle, and so on. So many mechanisms have been postulated. And this is a picture which all of us are familiar with, which shows the pathway of skeletal muscle insulin resistance in type 2 diabetes and metabolic syndrome. So the way probably in which the increased adipose tissue contributes to insulin resistance is by providing more of fat, source of fat close to the muscle. Because here we are talking about free fatty acids which are derived from the circulation from distant depots. Here we have a depot of fat right next to the muscle. So it stands to reason that more fat you have in the muscle, the more fat there is available locally as a fuel, and the more the insulin sensitivity can be decreased. And this is a recent study, a couple of recent studies I picked up. This is just published last month. And in this particular study, what they have done is, the exact details are far beyond me, but I'll just read it out. What they have done is they've taken human muscle cells, primary muscle cells, which are incubated with conditioned media from both intermuscular adipose tissue, visceral adipose tissue, and subcutaneous adipose tissue. And they found that the expression of genes related to insulin signaling, oxidative phosphorylation, peroxidal metabolism related positively to donor insulin. So it's probable that the intramuscular adipose tissue elaborates some of these cytokines which adversely affect all these pathways which are important in insulin sensitivity. So this is more evidence in favor of a direct pathogenic mechanism for insulin resistance caused by IMAT. And we have this another recent study which was published 2 months ago from the Cardia study in the US, which has clearly shown that higher IMAT value has been associated with higher prevalence of diabetes even after adjustment for the visceral adipose tissue volume. Earlier we were talking about BMI adjustment. Now we are talking about VAT, visceral adipose tissue. Even after adjusting for the visceral adipose tissue amount, the more IMAT you have, the more likely you have to have diabetes or pre-diabetes. Again, it's only an association, doesn't prove causality. It's very important to note that as you grow older, your muscle adiposity increases. We all know that when you grow older, the muscle mass decreases and you lose muscle strength. But it has long been known that the degree of loss of muscle strength is more than what can be explained by the loss of muscle tissue alone. So even if you lose 1% of muscle mass, you lose 4% of strength. So postulate here being that it's not only the loss of lean muscle mass, but the accumulation of adipose tissue which actually adversely impacts your functioning. And because of that, what happens is that there is decreased mobility, again which worsens your risk of getting metabolic disease. And there is a chance of muscle injury because your muscle structure gets affected when you have more of fat rather than muscle fibers. But the good point here is that it is not an inevitable consequence of aging. Just because you're old doesn't mean that you need to have more of adipose tissue in the muscle and you need to have more of muscle weakness. It is more a product of illness, disease, or inactivity. And the point here is that similar changes can be found in the muscle after forced inactivity at any age. Suppose you are 20, 30 years old and you have a fracture and you are immobilized. You see your muscle adipose tissue after 2 weeks of immobilization, you will see that it has gone up. So this is really nothing to do with aging, but it is more to do with your lifestyle factors such as level of physical activity. And this means that you can minimize the increase in IMAT by physical activity intervention. The point here being that you would start it early for maximum benefit. Because once you already accumulate a lot of adipose tissue in the muscle, as I said, the muscle functioning is affected. And similarly, old people, if you ask them to do more of exercise, they may end up in injury, they may fall down, fracture themselves, you may do more harm than good. So it is always better to start the exercise program early and to prevent the accumulation of IMAT rather than try and dissolve the IMAT once it has already formed. So multiple studies have assessed the effect of diet and exercise interventions on IMAT. Most studies have looked at resistance training, some have looked at aerobic exercise and calorie restrictions, and most have reported decreased IMAT following intervention. The thing is that many of them have not adjusted for decreases in BMI, total fat, visceral fat, and so on. The one point that has come out from most of these studies is that weight loss is an essential prerequisite to bring about changes in intramuscular adipose tissue. But it also depends how you achieve the weight loss. If you achieve weight loss by calorie restriction only, especially in older people, you may be doing more harm than good. So already frail person, you make them even frailer, you may not be doing them any good. So weight loss produced by exercise is superior to that produced by calorie restriction alone as far as the muscle strength is concerned. People have tried other things like electrical stimulation of muscle and so on, but that is more in people who have had a stroke or a spinal cord injury and it's only anecdotal reports. They also tried pharmacotherapy because now we know that in fatty liver people have looked at metformin, pioglitazone and so on and so forth because that's also an ectopic depot of the liver and studies are ongoing with the use of pioglitazone in these cases. Whether it can do something to redistribute the muscle between the muscle depot and the subcutaneous depot. So I'd like to conclude my brief talk by saying that intramuscular adipose tissue is a fat depot which is distinct from subcutaneous and visceral fat. From the available evidence, it looks to behave more like visceral fat than subcutaneous fat. And excess of intramuscular adipose tissue is found in conditions which are associated with insulin resistance, such as obesity and type 2 diabetes. It may have deleterious effects on muscle function and mobility, and which leads on to further increase in inactivity and further accumulation of intramuscular adipose tissue. At present, the only modalities which we have available to prevent our muscle from accumulating fat is physical activity with weight loss. And this has to be started early in the life course to have the maximum benefits. Thank you for your attention.